Okay, my watch now shows 11 o'clock. My name is Ken Plant. I'm the Health and Medical Program Manager for Mid-America Regional Council. And I'd like to welcome all of you here today for our webinar. Before we get started, I would like to voice my personal thanks to Dr. Gustafson, Dr. Reish, and Mike Wallace for all of the work they've done in helping to make this TCD plan that was recently adopted a reality, and for their willingness to be here today to serve as a speakers panel to talk about the plan, to help educate our region about the plan, and to answer any questions you might have. It's one thing to have a plan, but more importantly, we need to follow that plan. And to do that, you have to have a good understanding of the plan and how it works. So I think it's great that we have this opportunity today to talk about the plan. Our first speaker will be Mike Wallace, but before we do that, let's go ahead and take a moment and we'll go around the room and do some introductions. I would also like you to know that this webinar is being recorded, and I will send out information in the near future on where that recording will be housed so that anyone who was unable to attend today will be able to make up that training by watching the recording of today's webinar. With that said, I'm going to go ahead and get started. We'll begin with introductions here in the room, and then we'll take it out to our remote guest and let you introduce yourself and the agency that you are with. So again, my name is Ken Plant, and I will now pass the microphone on.
Paula McBride from Cass Regional in Harrisonville, Missouri.
Sam Jackson from St. Luke's Hospital in Kansas City.
Ken Kellwork, Medical Director of St. Mary's Hospital, Blue Springs.
Virginia Wilson, EMS Program Director of National American University.
Paul Winiger with AMR in Missouri.
Michael Addick, KCFD.
Tom Collins, KCFD.
Shalene King, St. Luke's Hospital Stroke Program.
Cameron Sintox, KCFD.
Dr. Dave Gustafson, Region A Chairman.
Jay Reish, Medical Director for Kansas City Fire Department and for Region A.
And Mike Wallace, TCD Chair for MARCER, as well as with AMR Independence.
And now if we could, our guests that are not here with us today, that are in remotely with us, if you could introduce yourselves.
Hi, Stacy Kearns, North Kansas City Hospital.
Derek Collins, St. Luke's Hospital.
Joe Maddock, Excelsior Springs Fire Department.
We got some stragglers out there, so feel free to unmute the button. All right, well, we're going to go ahead and get started. And again, thank you all for being here right at lunchtime, and thank you for those who are attending via the conference call. So what we're going to talk about is the Missouri TCD system. And as you know, our Kansas City Region A Community Plan was approved by the Department of Health and Senior Services as our individual community plan in accordance with the regulations that were adopted on the Missouri TCD system. Part of the requirements for us to have our community plan is we have to have an outreach to all of those agencies, departments that fall within the jurisdiction, if you will, of our particular plan. So the intent of today is to kind of walk through the plan and have a time where we can answer some questions that you might have. And again, this will be available online as well. The other thing I want to mention before we get started is if you haven't downloaded the most current plan, you can go to the MARCER website and download the TCD plan, or if you go to Google and type in Kansas City TCD plan, it will pop up and you'll have the most current plan available. So what we're going to do is we're going to have a conversation about a history of the plan, how it all began, what was the vision behind it, the project purpose and process, the EMS role in the TCD project, as well as the partnerships and responsibilities of the hospital's role in the time-critical diagnosis project. We'll talk about the TCD designations, where are we now, some of the challenges that we have, although we now have the stroke designations, and at some point we'll have the STEMI designation, but we'll talk about that, the next steps, and then of course finally the questions. So we'll go ahead and get started with, this is of no surprise to anybody, when we talk about the leading causes of death in the United States, and certainly we all know that the leading cause of death is heart disease, and that of course is including ST segment elevation MI for our patients. And certainly we can further look at that, see that stroke is the third leading cause of death, and of course fourth, of course, is trauma. When we take a look at specifically with Missouri, how well are we doing in comparison to the other areas of the United States? Well, we were 12.7% higher than the national rate and the 10th highest heart disease mortality of all 50 states. So when it comes to stroke, pretty similar statistics, 12.5% higher, and then the 14th highest stroke mortality rate. So our slogan is the show me state. So we're doing a pretty good job with that. But certainly when you take a look at this, you can see that it is indeed an issue. One of the other statistics that's out there is when we talk about the number of patients who activate emergency medical services for pain or stroke-like symptoms, and then of course how many of those patients actually get in a vehicle and drive themselves to the hospital. And of course we know that that's certainly a problem. So take a look at another way, and I think this is pretty telltale when we look at this. If you look at the Missouri heart disease and stroke deaths by county, and this is 99 through 2007, there's really no surprise. And so really when you look at this, the lighter colors are obviously the less death rates associated in the counties, and of course the darker you go, they have the higher death rates for STEMI and stroke. And so if you really tie in with that, the access to primary intervention, you can see that obviously as you move out from the urban centers, suburban centers into the rural areas, obviously access to timely care or reperfusion is a huge issue. I'll show you another way to kind of take a look at that. Access to timely care, this is something that was put out by the American Heart Association, and if you take a look at this map, you can definitely tell that the black dots are where you want to have a coronary event or a stroke. So the black dots represent the areas where patients or people have access within 1 hour to timely reperfusion. So if you look outside of those black dots, obviously there's a tremendous amount of area, not only in Missouri but in the United States, that patients do not have access to timely care. So there's certainly an issue not only in Missouri but around the United States as well. So the elephant in the room, obviously, is that rural areas, really have access. It's really challenging when it comes time for them to have access to stroke and STEMI reperfusion strategies. So, that's the big issue. So when we think about where this all began, it really began with the vision of Dr. Bill German, who felt that no matter where you lived in the state of Missouri, you should have access to timely care for stroke and STEMI. As a matter of fact, we'll talk about the history in the next slide, but he wrote a very pointed white paper in regards to this that there's a bullet point that we can't really find it, but basically blasted EMS care, access to care in the state of Missouri. So with Dr. Bill German, he believed that access should be equal no matter where you live, that we should look at our systems and eliminate any of those barriers, and he just felt that it was the right thing to do for Missouri. So his slogan was, let's get her done. So Dr. Bill German became the state EMS medical director in 2005, and that's really where he started launching the time-critical diagnosis. I mentioned the Missouri Foundation of Health. That's the white paper that was written in the early 2000s. Not even sure if it was published, but it called for a major change to the way that we treat patients with STEMI and stroke in the state of Missouri. So the Missouri Foundation of Health began to fund some conferences in 2000, early 2000, and in 2006, we began the emergency medical care system planning, which really took a look at STEMI and stroke treatment and care in the state of Missouri. The TCD task forces began in 2007 and 2008, and then, of course, authorizing legislation by the Missouri General Assembly happened in 2008. Now, what's interesting here is that with Dr. German's vision, he actually passed away on May 15th of 2008, okay, of an acute MI. On May 16th, the legislation was passed. One day after he passed away from an acute MI, the legislation in Missouri was passed to start the Missouri TCD system. So time-critical diagnosis implementation teams were formed in 2008 and continued. I remember the very first meetings we had were in September of 2008. We met at various locations, most of the time in Columbia, where we started to assemble all of the representatives from all the hospitals, the physicians, EMS services. There were several hundred people in attendance in those meetings, and began that processing or that project implementation plan. Went through several review processes, and then, of course, in March 6th of 2015, our official plan was actually approved by the Department of Health and Senior Services. So why does TCD matter? Well, it mattered to Dr. German, and it matters because ambulances often triage to the nearest hospital rather than what's the most appropriate hospital for the patient. And we all know that when it comes to patients with acute MI or ischemic stroke, getting that clot opened up and allowing for that reperfusion to occur does not occur at every particular hospital. So sometimes the closest hospital is not the most appropriate hospital. Patients who self-transport themselves, again, that 50% of patients who drive themselves to the hospital, may not have knowledge of what hospital they're going to. Is that going to be the most appropriate hospital for them? So that's a challenge. And of course, we know that rural populations face challenges as they relate to timely care, and we already kind of showed you that. So Dr. German began to look at models that were currently out there, and there were a lot of areas around the United States that were doing some pretty good work with this. But he didn't have to look very far in order to look at a system that actually exceeded the expectations on the implementation, and that's the modern trauma system. So we know that the trauma system agenda for the future exceeded expectations. There was actually a 50% reduction in trauma deaths. Delays were decreased from 54% to 7%, decrease in suboptimal care from 32% to 3%. That's pretty significant. And then looking around at other statewide initiatives, many of the states on the screen there were also looking for ways to improve the time for these patients who were having acute MI and stroke. So Dr. German thought maybe we need to model this system after the trauma system, and so that's indeed what they did. So that kind of gave birth to the TCD system with the goal of to improve health outcomes for all Missourians who suffer from STEMI and stroke, establish a functional system to improve transport, diagnosis, and treatment, with the big caveat to eliminate the barriers to reperfusion. Any of those processes that are in place, let's identify those and let's get rid of those. Have in place protocols, practices, and infrastructure that will evolve for continuing improvement and outcomes. And then, of course, with that, we get the continuum of care over on the right there that shows basically 360 degrees, 365 days of the year. So that's our emergency medical care system for time-critical diagnosis. So out of this comes lots of system recommendations. I'm going to talk about a few of these, and Dr. Rishi is going to talk about some of the specific ones for the hospital. But pre-hospital components in our KC plan and the Kansas City plan that you have, 911 EMD, that's where it kind of all starts. Of course, we would all say that it also starts with public education, and we'll talk about that. But having a good 911 EMD system, response coordination, having the ability for that call screening process, that priority dispatch to match the response to needs, get condition-specific pre-arrival instructions to the callers, And then for those folks that are in the rural areas, give them the ability for that early launch for medical helicopters when they're appropriate. And so in Appendix F in the back of the Kansas City plan, F and G, we actually have addendums that, or the appendixes cover that auto launch process for aeromedical service. Pre-hospital response and transport, up-to-date equipment and technology, talks about what the equipment is needed. So it outlines some triage and assessment processes, early activation, and again, that's a big thing that we're driving within our region is getting those resources activated as early as we can to start those processes within that receiving center. Transport protocols, of course, ground and air that are specified in that. Hospital system components, well, one of the things about the TCD system is that the hospitals can voluntarily participate in the TCD process, the designation. It's voluntary for the hospital services. It's important for us to understand as EMS providers that it is not a voluntary process. So we are required to abide by the regulation when it comes to the actual transport of our patients to the designated centers. Replication of the trauma system designation system, we'll talk about the level designations. Places have to provide, or facilities provide, stroke and STEMI program at all levels, having a medical director and a program manager coordinator. They have to have a one-call activation process. Transfer agreement are mandatory. I know in the initial versions of the plan, we didn't refer necessarily to that mandated, but when we did our initial application to the state for the plan for approval, they came back and cited the regulation there that said it's not optional that transferring facilities must have pre-arranged transfer agreements. Minimize diversions or out of service time, and then recognizing and fitting in where these small and rural hospitals, referral hospitals, how they can play a key role in the TCD system, where they fit in with that. Quality improvement, a big issue. We want data. It's the only way we're going to be able to tell the system is working, improving outcomes and things. Part of our committee plan is that we have a patient safety quality improvement subcommittee that we're kind of working through and defining those processes of data collection, how we can collect it, and then of course be able to share that information. That's going to be important. At all levels of the plan, pre-hospital and hospital, they talk about professional education. They have core competencies, continuing ed, that's specified as well. And of course, we know the public education piece. We can't overemphasize.
Yeah, just email me. I'll get it taken care of.
So here are our levels of designation. Of course, they mirror that of the trauma system. Level 1, obviously, is your big resource centers within the regions, all the way down to your level 4s, which are access hospitals, stabilization hospitals, stabilize, prepare for rapid transport to the higher levels of care. And we will go over the specific hospitals and where they fit in the level designations here in just a little bit. So when we come to the KC plan, what it specifies for the pre-hospital side of things is, of course, identification of stroke, the protocol, ensure ABCs are adequate, assess and treat for other causes than a stroke, that differential diagnosis, if you will, of course, assess that blood glucose to rule out hypoglycemia or, treat documented hypoglycemia. Perform that Cincinnati pre-hospital stroke scale. It is the stroke scale that we still recommend. If positive or strong suspicion, again, the important thing is determine that last known well. We can have that documentation of that. And then one of the things that the plan talks about is determine that thrombolytic exclusion criteria to see if it exists. So the EMS transport guidelines for stroke, and again, these are management guidelines. So as you can see, it's an italics up there, is that suggestive treatments only. It's important to understand that the local EMS medical directors can have a role in formulating these transport guidelines with the intent of the program as well. But stroke symptoms, 3.5 hours, transport to the closest stroke center with head CT, IV, TPA within 60 minutes. Outside that 3.5 hours, but less than 12 hours, transport to comprehensive level 1. Exclusion criteria present, transport to the closest stroke receiving center. And it does make a point to say that make contact with the physician at the closest center to determine or to discuss that diversion to that higher level of stroke care if in the event we have a patient that does not meet criteria. So that discussion does need to be had. Extended ground transport time, consider that helicopter utilization. As far as DLS transport units, transport that patient to the closest appropriate comprehensive primary stroke referral center for activation into the TCD plan. Specific to stroke EMS guidelines, again, supportive care. This is local protocol driven. Oxygen, of course, initiating IVs, cardiac monitor, treat patients, and of course treat with documented hypoglycemic patients with those. And again, the big thing is limiting that scene time, getting them to that appropriate facility as quick as they can. Utilizing the alerts to start those resources locally. I'm going to turn it over to Dr. Reish, who's going to discuss interfacility transfer guidelines for stroke.
Thank you, Mike. The number one and most important thing when getting involved in the interfacility transfer of patients is to have a pre-established MOU with your typical receiving facilities, and to have guidelines in place, protocols and policies in place to make this as much of a fluid and practiced procedure than it is something as a one-time, one-off basis. You may even try some practice runs and training on this is really helps. The second most important thing to do is for a transferring facility is if you're considering the diagnosis, if you're considering the transfer, notify EMS as soon as you can in the process. Get that ball rolling, because as we know, that's not an instantaneous process, and getting them aware that they have a potential TCD patient for transfer will help move things along. The referring hospital should obviously care for the patient until the transfer is arranged and accomplished. They should, for stroke, administer a thrombolytic and or arrange for transfer following the guidelines. If they cannot get the thrombolytic initiated rapidly, you don't want to delay care for more than 30 minutes. You want to get them out of your hospital within 30 minutes. If not, you want to get the thrombolytic started within a target goal of 60 minutes from arrival, and then patients can be transferred shortly after that. Some of the information that the receiving facility should get communicated by the referring facility is time last known normal. When was that patient last seen or last found where they were known to have no symptoms whatsoever? There should be a detailed neurological exam focusing on focal deficits that are found, level of consciousness, etc. Using the National Institute of Health Stroke Scale. While it's a complex process, it takes a few minutes. Once you've practiced it a number of times, you could complete that scale in about 5 minutes per patient. And it's a good baseline measure as well as to document any changes over time. Obviously, you want to complete the history. Obtaining a head CT is obviously utmost important before treatment. But you don't want to wait on getting copies, which in the old days, or getting an electronic version placed on a desk to do the transfer. That can always happen afterwards. Better yet, if you have a system in place where your receiving center radiologist can get direct electronic access to your scans, that's the best, because they can get it directly and instantaneously. Any and all lab results that are obtained should be sent along with the patient. If not, they could be referred later. Again, if the receiving facility can have direct access, that's even best. And then you need to evaluate if the patient actually is a true candidate for TPA. And you don't want to delay the transfer for anything. All they really need to go out the door is your MTALA transfer form. Everything else can be sent later, either by fax, electronically nowadays, especially if the hospital's within your network, or the old-fashioned way by courier. And if you refer to Appendix E, there's a sample transfer worksheet, that checklist that you could have ready to go at your facility. In terms of management, again, management is all local. It's based on your local protocols as well as the preferences of the receiving neurology department. But it's essentially established 2 peripheral IVs. Most hospitals prefer at least an 18 gauge or larger in the antecubital or proximal to that, because if they are going to do a CT angio, they need that size IV, and it would help reduce delay. Obviously, perform a statin non-contrast initial head CT and the appropriate lab work. You want to review the inclusion and exclusion criteria and discuss with the receiving neurologist whether or not the patient is a candidate for TPA at your facility or just transfer. There are tight blood pressure control guidelines, whether they are being TPA'd or not. Basically, you need to maintain the blood pressure below 180 over 110 if they're going to receive treatment, or a little bit higher if they're not going to get it, 220 over 120. Nursing should obtain and document vital signs and neurological checks every 15 minutes during this process. Obviously, to complete a report to the transferring team, including what medications you've given, any fluids you've given, how much TPA was given, when it was started, when it was going to complete. Again, maintain the blood pressure control, and frequent reassessments are vital, and documenting the such. So whether it's a basic scale or using the stroke scale, that will give you a clear measure and consistent information across providers. And finally, if something changes significantly, if the patient deteriorates, you want to stop your infusion and obtain another head CT. And now I'll turn this back over to Mike.
Thank you, Dr. Reich. So the stroke designations for our particular region were released, and so here they are. So our level 1, or comprehensive centers, level 1, of course, Research Medical Center, of course, St. Luke's Hospital on the Plaza. Our level 2s, Centerpoint Medical Center, Lee Summit Medical Center, St. Luke's, Lee Summit, St. Joseph Medical Center, of course, St. Mary's of Blue Springs. Moving down to level 3, Belton Regional Medical Center, and St. Luke's. That's essentially it on the Missouri side. Now, because we are bi-state and recognize the fact that for some of our EMS providers that are on the, they may be closer to a Kansas comprehensive or primary stroke center, the plan allows for that transport across state line like you normally would to provide that patient with stroke care. So we did list the Kansas centers, Comprehensive University of Kansas Hospital, primary, Menorah, Olathe Medical Center, Overland Park, Regional, Providence, and of course Shawnee Mission. These are all outlined in the back of the Kansas City plan in one of the appendixes, along with what will be the STEMI designations, as well as your current burn centers, trauma, pediatric, and all that. So as you can take a look at this, there are some gaps in coverage, especially as we move up north. Here in a little while, I'll talk about what processes are in place to be able to address those gaps in coverage. So let's shift now over to STEMI. And so bottom line, the guideline objectives for our STEMI care in our Kansas City plan and the TCD plan overall is that all patients with STEMI diagnosis will receive some sort of thrombolytic within 30 minutes of arrival to a hospital, or PCI within 90 minutes of that first medical contact for that patient. So obviously the reperfusion is critical. So all patients with suspected acute coronary syndrome shall have a quick assessment of airway, breathing, circulation, and acute coronary syndrome symptoms. This is identification. A 12E will be required and interpreted within 10 minutes of arrival at the patient's contact. In the case with the BLS service, the 12E ECG machine can interpret the STEMI or acute MI, or it can be sent to a receiving physician who can certainly make that diagnosis. And again, the benchmark still is within 10 minutes of arrival. Consider completing EKG and additional right-sided posterior leads, the 15-lead ECG when that particular particularly indicated or capable. EMS will notify the receiving facility that a patient with a STEMI has been identified. A lot of people use the standard STEMI alert, much like they would use a stroke alert. That seems to be a common way to notify that. STEMI receiving centers will respect the verbal notification, transmitted or faxed ECGs, or ECG computer interpretation of acute MI from an EMS service. And although many places are doing that and are embracing that, we still have a few that aren't necessarily doing that. STEMI receiving centers will activate their STEMI team upon notification by the EMS service. Patients presenting through the STEMI receiving center emergency department ED, all patients presenting with acute coronary syndrome symptoms will have a 12-lead ECG acquired, interpreted, pretty much follow streamline identification, much like pre-hospital or within the hospital. Again, consider looking at the right side, especially inferior wall MIs, extension to posteriors with inferior lateral walls, if that capability is present, and of course activate the STEMI team immediately upon identification of the STEMI. Patients presenting through the STEMI referral center emergency department, again, the timely acquisition within 10 minutes of the 12-lead. Again, further analysis for the presence of a right-sided MI or posterior wall MI. As we send those patients out, contact that EMS transport service as soon as possible, even if the receiving location is still not known. And again, you want to, just as Dr. Reese talked about the stroke, you want to identify that patient as a time-critical diagnosis patient to expedite that transfer process. Contact the STEMI receiving center as soon as possible. The STEMI receiving center will activate the STEMI team upon notification. So EMS transport guidelines, EMS will transport all patients with identified STEMI directly to the, and again there's that word, appropriate STEMI receiving center that requires the shortest transport time. So considering geography, weather conditions, air medical transport, helicopter utilization may be the way you need to go with that. EMS services will give due consideration to the goal of 90 minutes or less from first medical contact to PCI or balloon. When there's not a STEMI receiving center proximate enough to achieve the first medical contact, then that's where they may need to use an air ambulance rendezvous. But patients certainly may be transported to the closest STEMI referral center. When the EMS unit is BLS or unable to identify a STEMI patient, the patient can be transported to the closest appropriate hospital. I'm going to talk about the last bullet point there when it comes to the patient's request to transport to a specific hospital here in the next couple of slides specific. EMS management guidelines, again, this is local medical director driven. These are guidelines as well, so of course we want to definitely get the aspirin on board as quickly as we can. And of course respecting those patients where aspirin is contraindicated. And then of course consider sublingual nitroglycerin if it's within your protocol, and again keeping into consideration the indications and contraindications of the administration of that medication. Consider analgesia or medications for nausea, and of course any type of analgesia with that blood pressure. Of course, same with nitro to be above 100. Again, protocol driven. Dr. Reese.
Thank you. Again, with the in-facility transfer of patients and having a STEMI similar to having a stroke, it's very much encouraged to have a written MOU with your typical receiving facility in place ahead of time, and to have the transfer protocols and procedures to be followed, outlined clearly and practiced frequently. While you might have an agreement within your system or with your local nearest STEMI receiving facility or STEMI center, again, as Mike alluded to, the patient preference trumps all that, and patients do have a right to decide where they go, even if it's not necessarily in their best interest. Obviously, patients should be given all the information, and families should be given all the information, and encouraged to go to the nearest appropriate facility. And if they, decide not to, just document that clearly for medical legal purposes, and should comply with patient wishes. The STEMI referral center should administer TPA if the patient cannot get transferred in a timely fashion. The obvious goal is from first presentation to balloon up in 90 minutes or less. Obviously, you should communicate to your center where you're sending the patient, time of onset of the chest pain or equivalent symptoms, where the ST elevations or where the MI is located. Is it an anterior, is it an inferior, is it a posterior, is it an RV infarct, etc. What's the patient's general condition now, and what treatments you've already established for the patient. Again, similar to stroke, you have to delay your transfer at all due to paperwork or copying a chart, providing copies of x-rays or EKGs, etc. You only need your MCALA transfer paperwork. Everything else can follow the patient later. Again, if they're part of your system, or you can arrange for the receiving facility to have access to your records, that's the best. And again, if for some reason you have to delay transfer, then you should begin treatment with TPA. Some of the management guidelines, and this is another reason why you need to have a good relationship with your receiving facility, because each cardiologist or cardiology team will have different preferences in terms of what medications they would like on board or be administered early on, because it does affect what they do, whether they take them to the cath lab, etc. So having a pre-formed protocol and management protocol is important. Obviously, again, if EMS for some reason didn't do it, patients should get aspirin unless it's contraindicated or if they are allergic. But if they don't need to get it again. Depending, again, on the cardiologist's preference, either an antiplatelet or an anticoagulation medication can be administered. You really want to reduce the number of IV infusions if possible, because that just takes additional time for your EMS transferring agency to switch patients over. So anything that you could be probably given by mouth or not done by continuous infusion is the best to avoid delays. Again, the receiving center, they should again have the process pre-established and make it as easy for you to arrange the transfer. One call is usually the best. STEMI centers should avoid diverting patients, with the exception of if they cannot handle because they have both all their cath labs are full or out of service. But then there should be a process in place for recommending additional management until that transfer can occur. You also want to, your STEMI center is going to want to help verify that you actually have a patient with acute MI and a STEMI, how long it took to get to the intervention, and what the patient's condition is. Right?
All right, so as the slide says, designated STEMI centers in the KC plan. There are none in the appendix, and there are none designated by the state of Missouri. The application period for STEMI designation closed in June. That was the deadline for applications. No surveys have yet begun, and there's no ETA from the state as of this morning as to when the STEMI designations will actually be released. Much like they did the stroke designations, they will all be released at one time, but again, there's no announcement. So business as usual for the transport of your STEMI patients. Again, keeping in mind that we get them to the most appropriate facility where they can get that artery opened up. Kind of revisiting this, there are a couple of things that allow for EMS services to transport that patient to the facility that they want to go to, and it may not be the most appropriate facility, as Dr. Reed talked about, is the patient preference, family preference, whatever patient preference does trump the TCD requirements. When this happens, this has to be documented in the patient care report. If it's obviously transport, if the request is to transport to a facility that is probably not appropriate, then it's required of us to obviously educate that patient and family as to why we feel it's not a good idea to transport, and that we need to be taken into the most appropriate center. But bottom line, document their desire where they want to go and do that. The second thing that allows for EMS services to not transport to the level designated hospital is that a patient that needs stabilization. Stabilization is very broad. Services could look at that, and I need to report into this facility for this stabilization or whatever. This deviation and transports for stabilization must be clearly documented in your patient care report. One of the things that the state was very clear on is that as they look into these, whether it's a complaint or whatever, they will look to see, is there a service that is transporting to a closer facility for, quote, stabilization? And if so, they'll look closer into those. So these are the only two mechanisms in place for EMS services to transport TCD patients to non-TCD facilities. I failed to mention that the Kansas City plan, or the TCD plan, also covers trauma. And although we didn't talk specifically about trauma, trauma is essentially unchanged to what we currently do. So that's why it was not necessarily talked about in this particular presentation. But trauma is mentioned, trauma criteria, et cetera, is mentioned in the Kansas City plan. So where are we now? Well, of course, you can get your plan at marc.org. Like I said, the Google search will pull it up. The Department of Health and Senior Services in the process of designated hospitals where the significant gaps were found. An update from the department as of this morning is that new applications can still be submitted for designation. If the hospital is Joint Commission accredited for the same level of stroke designation that they're requesting from the state, then they will move that survey up, and they're usually looking at about 3 months before that survey can actually be done. And that's essentially it. Applications for the STEMI, of course, I mentioned, has been closed. They're putting together the site reviewers, and there's no, it's unknown when these designations will certainly be released. I mentioned Kansas City Community Plan reviews. We do have a committee at MARCER that will be reviewing the plan once all the designations are out. As far as changing any of the plans as it changes to the dynamic nature of medicine, it creates a little problem for us. Any change that we want to do to a particular section of our plan requires a complete reapproval at the state level for the plan in its entirety. The state has made it very clear that they're not open at this particular point to any such evaluations or reapproval of the plans. So we kind of have to, kind of be careful with that process. So there is a process for changing your plan, and at MARC we will be, of course, monitoring the plan and making sure that we are where we need to be with evidence-based medicine. There's the, if you want more information on this, stroke symptoms, blah, 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 the TCD plan, you can find it at the Missouri Department website. It's health.mo.gov, and that's also where you can find the plan as well. So I'll turn it over to Ken.
Also available on EM Resources.
And it's also available on EM Resources. Under Documents. Okay. So I think the intent now is to open it up for questions for for those who are present in the room and those who are attending via the webinar.
Any questions from anyone out connecting with us through the webinar?
Tony Mann, the University of Kansas Hospital. I have a question.
Go ahead.
All right, so the only accrediting body that we're using within the MARCER plan is the Joint Commission. We don't recognize DNV or HVAP as designated or as designators for the hospitals.
I think it is Joint Commission.
Is it just Joint Commission, no other accrediting body?
You're talking about for the state's designation?
Okay, so on the Kansas side, if we're not part of your Missouri designation.
On the Kansas side, it is the Joint Commission designation.
Joint Commission only, is that what I hear?
Yes.
Okay, thanks.
Hey, Mike Joe-Matic from Excelsior Springs. We have a referring center here in our town that we get transfers from occasionally on stroke patients, and they're transferring these patients to non-designated centers. Are we able to transfer them to a designated center?
So you have EMS systems that are bringing patients to you?
No, we have a hospital that is arranging transfers of stroke patients to non-designated centers. Do we have to abide by that?
That particular issue created quite a mix at the state level as far as clarification. And the last thing that I know is that once those transfer agreements are made, that EMS services just honor those transfer agreements from hospital A to hospital B, even though they may not be a TCD center.
So you're getting patients to your facility that you don't feel is appropriate for your facility? Is that what you're saying?
Well, we're getting transfers of patients to hospitals that are not designated as stroke centers.
Oh,
that is an interfacility transfer.
As an interfacility transfer.
Right.
Yeah. Unfortunately, as Mike just said, the state was very clear that once an established relationship, or once the hospital has decided to send a patient from hospital A to hospital B, that has to be honored, even though it's not necessarily to what EMS would feel would be the right center.
Okay.
Any other questions from people on the phone?
Any questions here?
Let's see if anybody, they pop up on the screen. We're going to check online quickly to see if anybody had a question. Check log. Just go to the main right now. None. No, doesn't look like question.
Ken, what would be the process for those who will be reviewing this later for them to be able to submit questions? Just email?
If there's any questions viewing this webinar at a later date, if you can email them to me at kplante@marc.org. And I will see that it is sent out to our panel of speakers, and we ensure that those questions are answered. If there are no other questions, your last chance to ask a question. Any questions? The question is Joe Mack still on the teleconference?
Joe Maddox.
Joe Mack.
Yes, I am.
The question is, do you need additional education for your local hospitals, and do you think that is why the breakdown is occurring?
We possibly could, but I would rather do that at a private time.
No, of course. I think the offer was just being made for additional resources to help you educate your facilities.
I think that's something that definitely needs to be considered.
And we can help to facilitate that.
Okay.
Any other questions? With no other questions then that'll bring us to closure on today's webinar. I thank all of you, both in the room and those attending by webinar, for your participation in our first attempt at a webinar. Again, there will be information coming out through the MARC organization to both the MARCER committee, the hospital committee, letting you know where this video will be available once we have finished the recording and decided where it will be housed. So thank you for your attendance, and hopefully we'll see you again in a future webinar. Take care.